Okay, well, I'm really pleased to be here. I think many of you know me. I'm Anita Chopra. I'm the director of the New Jersey Institute for Successful Aging. So today, actually, I'll be talking about clinical implications of aging physiology and really how it impacts to you guys who work in the emergency room, because I'm not going to cover all the systems, really going to focus on what you actually see in the emergency room and how actually aging related changes impact on the way you actually provide care to our older patients. So as I have said, that we've been really working very collaboratively, Dr. Scally and the other emergency room attendings in developing this geriatric curriculum, and we do actually hope to disseminate it nationally, because there's really no good geriatric ER curriculum which has been developed across the nation. So the learning objectives today are that I'll talk about this concept of homeostasis. Some of you may have heard about it. And then we'll review the physiological changes associated with age in various systems of the body. And we'll talk about the significance of age-associated physiologic changes on the clinical presentation and management of older patients. So I'm just going to start with a question. You guys actually can read it. I'm going to give you a little time. Sorry. Okay, so here are the questions. Which age-related physiologic change makes this patient more vulnerable to develop symptoms of congestive heart failure? Decline in renal function, hypoxia, increase in atrial natriuretic peptide levels, increase in blood pressure, and tachycardia and loss of atrial kick. And you guys can answer the question. Okay. All right, so we have some variability as to how we answered that question. So I'll talk about that. I mean, I just have these 3 questions which are like a pretest. Okay, so the next question. 80-year-old white male complains of mild shortness of breath on exertion. He denies any chest pain, wheezing, or cough. There's no history of hypertension or coronary artery disease. He denies a history of smoking. On examination, his lungs are clear with no crackles or wheezing. X-ray of the chest and electrocardiogram reveal normal findings. Patient is referred for pulmonary function tests. Okay, which of the following describes expected age-related changes in pulmonary function? It's a little too wordy, but first is decrease in total lung capacity, decreased in FEV1, decreased residual volume. Second is increased total lung capacity, decreased FEV1, and decreased residual volume. C is increased total lung capacity, decreased FEV1, and increased residual volume. Number 4 is stable total lung capacity, decreased vital capacity, and decreased residual volume. And E is stable total lung capacity, decreased vital capacity, and increased residual volume. Okay, so 46%, then 25% had answered D, and so it's varying. Nobody answered A, so we'll talk about that. The third question is, which aspect of renal function is relatively maintained with aging? Ability to excrete acid load, concentrating capacity, diluting capacity, erythropoietin production, and metabolism of parathyroid hormone. Okay, we are all over the place. Okay, all right, so I'll talk about that when we talk about renal system. So let's just now talk about aging, and I'll discuss those questions as we go through different systems. So we know that even though aging is associated with increase in the prevalence of diseases. In fact, chronic diseases are very common as people get older, but aging itself is not a disease. We also know that chronological age and physiologic age are not the same. I mean, we have seen 85-year-old running marathons, whereas other 85-year-old could be in the nursing homes and having a lot of a debilitating issue. So older people are very heterogeneous group. So I think we just can't make decisions on the basis of age. And I'm sure that you come across that you may have 85-year-old who's very vibrant, doesn't have that many comorbidities. Now that person can expect to live another 7 or 8 years, whereas somebody who is functionally dependent, their life expectancy may be just 2 to 3 years. So I think I'm sure that when you deal with emergent situations and you have to make decisions, so we really need to look at the overall functional status of an older person and what comorbidities they have before we make decisions. I actually just had a 94-year-old patient who was pretty functional. She lived independently, and she just had the aortic procedure. She had aortic stenosis, and they didn't want to undergo replacement of the aortic valve, so she just had the new procedure, which is putting a catheter in there. So I think age is not a contraindication to some of the procedures we do, but at the same time, I think we have to keep in mind that we are not being too aggressive to people at the end of their life who cannot benefit from all the aggressive approaches we have. In fact, they just released a report regarding New Jersey. If you go on this Dartmouth Atlas, they actually report on how nationally different states are doing and how different hospitals are doing. And it's been shown that New Jersey actually is #1 in spending money on patients at the last 2 years of their life. The number of doctors they see, the number of specialists they see, and New Jersey is also #1 in spending money on individuals at the last 6 months of their life. So we really need to move more into palliative care, because in this era of when the costs of healthcare are going so high, we just have to be judicious in our approaches. I mean, we don't want to deny treatment to older patients, but at the same time, we don't need to be so aggressive when we see that there's not going to be any benefits to their function or their quality of life. So individuals do age at different rates, and even within different organ systems, that the rate of change may be different. And we do know that there is increased susceptibility to diseases as older individuals advance in their age. I mentioned a little bit about spectrum of aging. I mean, you have older individuals who have disease and disability. Then we talk about usual aging, because many of the individuals may not have overt pathology, but they may have, for example, asymptomatic coronary artery disease is quite common in older patients, but they may not be symptomatic from that. And then we, classify some individuals having so-called successful aging, that they have little or no pathology and they have no functional loss. So these are really your vibrant, healthy individuals who really don't have that many comorbid diseases, and their life expectancy is a lot greater as compared to individuals who have comorbid diseases and also functional problems. So when we talk about homeostenosis, what I mean by that is that with aging, there is decline in almost every function of the body. Whether you have cardiovascular system, pulmonary system, renal system, endocrine system, every system declines to some extent. But the difference between older patients and younger patients is that they are able to function okay under normal circumstances. But when they have to undergo stress, and we know that acute illness or hospitalization is a major stress to older patients, that's the time that they actually start to decompensate. So one system decompensate, and then it leads to another system decompensating, and we call that as the term that there is homeostenosis, that there is inability for an older person to handle or maintain homeostasis under stressful conditions. We also know that disease present atypically in old age. For example, acute confusion is a very common presentation for medical illness. About 1/3 of the patients with myocardial infarction actually do not present with chest pain. So older patients are a lot more challenging to take care of. And diseases in old age, again, are modified by the comorbidities they have and also the age-related changes which they have because of advancing age. And the geriatric syndromes, so-called delirium, dementia, falls, urinary incontinence, they are not just related to one factor. In younger patients, you have one disease, and then you have symptoms related to that. The presentation is just focused on that disease, then you treat that individual disease and you're okay. Whereas you have problems like falls or delirium, they are multifactorial. We will talk about delirium. It's you could have as simple as somebody relocating from their environment could actually precipitate people to have delirium. So these are multifactorial problems, and you need multifactorial interventions. Just having one intervention is not going to be helping you with taking care of patients. You have seen falls. Falls are multifactorial. You have extrinsic factor, you have intrinsic factors. So these people really require comprehensive evaluation, and we need multifactorial interventions. So just going back to physiology of aging, we know that there is attenuation of pulsatile secretion of hormones like melatonin, ACTH, TSH, growth hormone. There is reduction in circadian amplitude of physiologic processes, for example, plasma cortisol, sleep, body temperature. And what happens is that you actually have loss of complexity of physiologic functions. Body is very adaptive, that in response to stress, different functions can adapt very quickly, but that complexity actually is not there as patients get older. So if you, for example, look at the effect of age on heart rate variability. Now, it may not have that much of a clinical significance in real life, but this really demonstrates that how the complexity, the way body handles the physiology is decreased, and it's actually is called like loss of spectral reserve. So in a younger person, you can see that there is complexity of this heart rate variability, and that decreases when people get older. And then age-related decline in heart rate variability is related to a number of factors. For example, there's dropout of sinus node cells, altered beta-adrenergic receptor responsiveness, and an apparent reduction in parasympathetic tone as people get older. Again, multiple factors can contribute towards that. I want to spend a little bit time about aging and homeostatic challenges like blood pressure, volume regulation, and temperature regulation, because I think that's something you do see when in the emergency room when you're dealing with older patients. So this is a patient, 80-year-old male, presents with complaints of dizziness, especially in the early afternoon. He reports that he has fainted once, but wasn't seriously injured at this time. His medical history includes COPD, peripheral vascular disease, hypertension. His hypertension is currently being treated with hydrochlorothiazide and felopatine, which is a calcium channel blocker. So the question is, what age-related changes are contributing to his dizziness or syncope? Decreased fluid volume, impaired cerebral autoregulation, orthostatic hypotension, and postprandial hypotension, and all of the above. Okay, so let's majority of you got it right, that there are many, it's multifactorial, but I think some of you and few of you answered B, which all these are true, but I think all these factors can actually contribute to a patient's dizziness. So let's just talk about aging and blood pressure regulation. We know that The baroreceptors, which are present in the aorta as well as in the carotids, their responsiveness does decrease as people get older. So they respond to arterial pressure changes, and that response progressively declines with age, resulting in increased risk of orthostatic hypotension. Also, there is a reduced adrenergic responsiveness by the aged heart. It diminishes baroreflex-mediated cardio acceleration in response to hypotension. We also know that with aging, there is decrease in cerebral blood flow for about 20%. And normally, if the blood pressure goes down, the cerebral autoregulation actually adjusts or adapts to that blood flow, but that decreases in older patients, especially patients who actually suffer from hypertension, that their cerebral autoregulation decreases. That's why it's not a good idea if a person is having a blood pressure of 180 or 190 that they are actually walking around with that, and we lower their pressure to 120 very fast, because that's what's going to happen is that then they're going to start feeling dizzy because they don't have the ability to have that autoregulation. So all those factors can contribute towards dizziness in an older person. We should also keep in mind an entity called like postprandial hypotension. There is decline in blood pressure after a meal, and that's quite common in patients who are older. So, sometimes you may see patients who come to the emergency room. I mean, they have syncope or dizziness, and we are trying to investigate all the different systems, and sometimes you don't have an answer to why the patient passed out. Because the reason for that, it could be multiple factors. Maybe it was after a meal, maybe they had some blood pressure medication, which was a vasodilator, which was given before meals. So all these factors could contribute towards patient passing out. Also, we know that certain medications like nitrates, diuretics, and antihypertensive medication can increase the risk of orthostatic and postprandial hypotension. So older patients, as I mentioned, are vulnerable to cerebral ischemia and syncope. So let's spend a little time on waging and volume regulation. So you have two patients. One is 25-year-old, fluid deprivation for 72 hours. Patient had sore throat. Sodium, you do their blood work. Sodium, no change. BUN, no change. Serum creatinine, no change. And mild hypotension with sinus tachycardia. So the patient is somewhat dehydrated. But just look at the patient who's 80-year-old. You just deprive them for fluid for 24 hours. She was made NPO. There were no IV fluids were ordered. And when you do tests on her, her sodium is now high. BUN is high. Serum creatinine, of course, no change. And even the cardiovascular response is not that much. I mean, she's not really that tachycardic. She does have hypotension with sinus tachycardia of 100. And I think the point I want to make is that many times you see patients in the emergency room who actually come from nursing home, and their sodiums are quite high. They may have 150 or 160. And I think sometimes the tendency may be to say, well, the nursing home was not really taking care of these patients. They were not giving them adequate fluids. But that may not be the case, because it doesn't take too long. It could be just 24 to 48 hours that the patient actually is not feeling good, they are not drinking enough fluids, and their sodium level can go high. So I think we just have to make sure if we make comments to the family regarding that, because sometimes I've gotten feedback, the families will then go to the nursing home and say, well, why did you get my loved one dehydrated? Why you guys were not taking care of them? But sometimes it may be true, but these things do happen pretty quickly. So let's just question related to that. Which of the following statements about age-related changes in sodium and water homeostasis is not true? There is impaired conservation of sodium and water. Hypernatremia may occur without clinical signs of dehydration. ANP levels are decreased, and there is decrease in renal responsiveness to ANP. Okay. So actually the answer here is that this is wrong. Atrial natriuretic levels are decreased. They actually do increase with aging, though there's a less the renal, there's decrease in renal response to ANP. Okay. So again, what are the clinical implications? I mean, some of it I already talked to, that there is decrease in total body water as a percentage of body weight as we get older, and related to because there is increase in fat. There's decreased thirst drive, decreased antidiuretic hormone response to hypovolemia, decreased maximum urinary concentration, and impaired access to water due to physical or cognitive disorders, which can happen in patients who are in the nursing home. So actually, you have problems with concentration urine. I mean, you and I, if we don't drink fluid for 48 hours, I mean, we are able to concentrate our urine, but that doesn't happen in older patients. So the concentrating ability is diminished. That's why older people are more prone to have dehydration, especially hypernatremic dehydration. And the same thing is true, that if you give actually too much volume load or sodium load, especially the volume overload, that can actually lead to hyponatremia and fluid overload. So that's why when we are replacing IV fluids in an older person, that we have to be careful that we don't push them into congestive heart failure. Okay, so we'll just spend a little time about talking about aging and thermoregulation, because I'm sure you see patients who have hypothermia and hyperthermia. We know that basal heat production decreases by 20% from age 30 years to age 70 due to active muscle loss. With age, the ability to regulate body temperature and to adapt to different thermal environments does decline. That's why older people are more prone to hyper and hypothermia. So let's look at this patient. She is an 88-year-old woman who lives alone. She has history of osteoarthritis of her hips and knees. One night while going to the bathroom, she fell. Unable to get up or call for help, Mrs. S. she laid on the bathroom floor until her daughter found her the next day, and she called the ambulance to bring her to the emergency room. She doesn't complain of any pain. On examination, she's lethargic and somewhat confused. Her skin is cold and pale. Blood pressure is 110/60, pulse 60 per minute. Rectal temperature is 95. And X-ray reveals no evidence of fracture. So what age-related changes make her more vulnerable to develop hypothermia? A, decreased production of thyroid hormone, impaired blood redistribution from splanchnic circulation, impaired skin vasodilatation response, reduced muscle activity and less shivering, and decrease in basal metabolic rate. Okay. The answer actually is D. There is less muscle mass and reduced shivering, so there's less of heat production as people get older. Okay, so just going to the questions, there is not actually decreased production of thyroid hormone. I mean, the T4 production may decrease, but the metabolism of actually T4 also decreases. So you are able to maintain a euthyroid state. This actually is more important when you're talking about patients with hyperthermia. There is, again, the same thing would be true for patients, whether you have more like an impaired skin vasoconstrictor response in order to conserve heat. So this is true. I mean, that plays some role, but I think this is the most important factor when we are dealing with patients who have hypothermia. So again, I think I just talked about reduced muscle activity, impaired vasoconstrictor response to cooling, reduced meal-induced thermogenesis as people get older, delayed perception of being cold, and difficulty in discriminating temperature differences. So all these factors can actually make an older person more prone to have hypothermia. So let's talk about now hyperthermia. This is an 80-year-old female. She's found unresponsive in her apartment on a hot summer day. Didn't have air conditioning. She has history of mild dementia, congestive heart failure, and Parkinson's disease. Medications include enalapril, furosemide, Sinemet. In the emergency room, her blood pressure is 85/50, pulse 100, rectal temperature is 105, and her skin is hot and dry. Okay, what age-related changes predispose an elderly person to heat stroke and its consequences? Reduced muscle activity, increased threshold to initiate sweating, impaired vasoconstrictor response, impaired ability to conserve heat, increased output of acrine sweat glands. Majority of you answered B. Okay, so that's the correct response. Okay. So again, impaired skin vasodilatation response, and impaired blood flow redistribution from splanchnic and renal circulation. So you could actually, lose more heat, decrease thirst, and this is the right answer. Increased threshold temperature to initiate sweating. There is actually decreased output of acrine sweat glands, and some of the medications can impair the response to heat, like such as anticholinergic agents, diuretics, and beta blockers, and all these medications actually can increase the risk of heat stroke. We hear warnings when the temperature really goes down. I mean, even in Philadelphia, there'll be warnings that the older patients, if they don't have air conditioning and they are on certain medication, that they are actually at risk for having heat strokes. Okay. Just a word about fever response in the elderly, that I'm sure you've all seen that people can be septic and they may not have temperature. Absence of temperature doesn't rule out that they don't have serious infection, because ability to raise body temperature in response to pyrogens is blunted with age. Up to 25% of the older persons with sepsis do not have a febrile reaction. Some people have looked at the definition of fever. They think that change from baseline may be the way to go, rather than looking at actually the temperature. So another definition of fever is a temperature increase of greater than 2 degrees Fahrenheit over baseline if the baseline temperature is available. And that has been used in patients who are institutionalized, where they are taking, they know what their baseline temperature is. Now just switch to cardiovascular system, and which of the following is not true about age-related cardiac changes? Resting cardiac output is unchanged, ejection fraction is reduced, early diastolic filling is reduced, and end diastolic filling is increased. Okay, so I think we had answer kind of widespread. So the correct answer was that the ejection fraction is not reduced. That's a wrong answer, that ejection fraction actually remains the same. Resting cardiac output does not change, even though with exercise cardiac output changes. And I'll talk about what happens to the diastolic filling, because I think that is a very important change which occurs as patients get older and do have an impact on especially patients who go into atrial fibrillation. So let's talk about cardiovascular system in terms of anatomy or structure of cardiovascular system. We know that there's decreased compliance of the arterial tree. The arteries become stiffer, so that leads to increased afterload on left ventricular and left ventricular hypertrophy. There's also increase in systolic and pulse pressure, and we know that systolic hypertension has adverse consequences. We used to say that the blood pressure of 160 was okay, but that's not the case. We need to have older patients also having the same guidelines that their blood pressure should be 140 systolic or below. Now, we do have to keep in mind that, some of my patients, I'm not able to achieve their blood pressure down to 140 because when I lower their pressure, they actually start having symptoms of dizziness. So we always have to weigh the risks versus benefits. But there's no separate guidelines for blood pressure control in elderly as compared to younger individual. The same guidelines apply. And also it's been shown that actually the pulse pressure, the difference between systolic and diastolic pressure is a prognostic indicator for patients having cardiovascular events and also increased mortality. As far as myocardial cells, we know there is some atrophy, there's increase in interstitial fibrosis, dropout of cardiac myocytes, and that does result in slowing of ventricular relaxation. There is increase in left ventricular compliance and increased contribution of atrial contraction to left ventricular and diastolic volume, because in early phases there is actually less blood because the heart is not as stiff and not able to dilate, so there is less early diastolic filling. So in older patients do depend on late diastolic filling to make sure that the heart so they have enough, they can generate enough stroke volume and cardiac output. We know that there is apoptosis of SA pacemaker cells, fibrosis and loss of his bundle cells, and there is some decrease in intrinsic heart rate, but really no clinical significance. But we know that sick sinus syndrome or heart blocks are much more common in older patients as compared to a younger individual. As far as other changes, I mentioned before that there is decreased responsiveness to beta adrenergic stimulation and reactivity to baroreceptors and chemoreceptors. So the older heart actually behaves like a younger heart on beta blockers, that there is decreased responsiveness to beta adrenergic stimulation. We know that the levels of circulating catecholamines, basal as well as stimulated, are higher in older patients as compared to younger patients. There is fibrosis and calcification of heart valves, and aortic valve sclerosis and stenosis we know is common. It's not uncommon to hear a systolic ejection murmur in an older individual, which may not be hemodynamically significant, even though we know that aortic stenosis is also a disease of the elderly. So this, I think, slide illustrates the difference between a younger patient and an older person. If you look at the time during diastole, for a younger patient, there is a lot more early diastolic filling as compared to an older person, that you don't have that much diastolic filling in the early phase, but the older heart really depends on this late diastolic filling. So that's why the atrial contraction actually is very important, because that plays a very important role in late diastolic filling. That's why when patients go into atrial fibrillation, they lose that atrial kick. And also when patients are tachycardic, there is not that much time for diastolic filling. So it's very easy for patients to go into congestive heart failure when they have tachycardia as well as atrial fibrillation. So I think the question we posed, the first one, was the answer is that tachycardia and loss of atrial kick actually makes an older person more prone to have congestive heart failure. In terms of cardiovascular physiology, the basal heart rate really does not change that much, but there is a decrease in maximum heart rate. Resting cardiac output remains the same, because even though there is slight decrease in heart rate, your stroke volume actually increases to compensate for that. But maximum cardiac output at exercise does decline. There is decrease in maximum aerobic capacity, decrease in cardiovascular reserve, so there is decreased threshold for congestive heart failure and atrial fibrillation. Now some of these effects which occur in cardiovascular system, Some are related to aging, but some are also related to disuse. So we know that people who exercise, I mean, even older patients, it's been shown that once they exercise, their VO2 max actually could be increased. So some of the effect is related to what we do in terms of exercise and other lifestyle modifications we can do. Just summarizing the clinical implications, systolic hypertension and widened pulse pressure are risk factors for stroke, renal failure, and heart disease. Age is the strongest predictor of mortality following acute MI. Diastolic heart failure, where ejection fraction is normal, accounts for as many as 50% of congestive heart failure patients over the age of 65. So you always may not have congestive heart failure related to systolic dysfunction, but diastolic heart failure is common, especially in patients who have diabetes and hypertension. Atrial fibrillation, again, as I mentioned, this becomes more of a physiologic burden to the older heart because of age-related slowing of diastolic filling due to left ventricular stiffness and greater dependence for adequate filling on atrial contraction. So I think physiologically it's quite important. So I'm going to skip this question. So the correct answer was tachycardia and loss of atrial kick. Okay, now respiratory system. We know that there is stiffness of chest wall. So the work of breathing does increase. Actually, the chest wall compliance, compliance actually decreases because of increase in the stiffness. Whereas the opposite thing happens, that there is decreased lung elasticity and elastic recoil. So actually your compliance increases. We know that there is enlargement of alveolar ducts and decrease in alveolar surface area, lower respiratory muscle strength and endurance as people get older, and decrease in cough and mucociliary clearance, which does make an older person more prone to have respiratory infections. Just effect of aging on lung function, and we had a question related to that. I think many of you got the right answer. With aging, there is lower maximum expiratory flows. FEV1, FEV1 to FEV loss is approximately 15 to 30 cc's per year in FEV1 from the peak achieved at age 25 to 30 years. So actually, the total lung capacity remains the same, but there is a decrease in vital capacity and increase in functional residual capacity and residual volume. We also know that PaO2 declines linearly with aging until age 75, at which time it stabilizes around 80 millimeter of mercury in healthy non-smokers. And this decrease in PaO2 is because of ventilation perfusion mismatch. That's caused by age-related collapse of peripheral airways, especially at the bases, leading to shunting of blood through non-ventilated alveoli. And this is just an approximate formula that you can use, that PaO2 at any age can be roughly estimated by the equation PaO2 is equal to 100 minus 0.3 times age. And with aging, there is also lower diffusing capacity and reduced respiratory drive for hypoxia and hypercarbia. So clinical implications, more problems with respiratory failure. Also, we have to keep in mind that non-pulmonary conditions, and I'm sure that you see that in the emergency room, such as congestive heart failures, cerebrovascular accidents, nutritional disorders can also precipitate respiratory failure in the elderly. In older patients, the complaint of dyspnea must be taken seriously because older adults may not develop this symptom until they are at later stages in their illness. And that's something I always keep in mind when they call us from the nursing home. Patient may be having cough and fever. You are trying to differentiate whether it is from the upper respiratory tract infection or lower respiratory tract infection. So I always ask them that do they have any dyspnea. So if they are short of breath, then we have to be a lot more concerned about that they may not have lower respiratory tract infection. So elderly have 5 to 10-fold increased risk of pneumonia as compared to younger adults and are much more likely to die from this disease than their younger counterparts. Moving on, I think we already covered that question. So, the answer was stable total lung capacity, decreased vital capacity, and increased residual volume. So renal system, there is general decline in GFR by about 1 milliliter per year after 40. So, when we talk about usual aging, many of the individuals do have comorbidities and they have decline in renal function. But it was interesting that in the Baltimore longitudinal study of aging, which actually was started in 1950s, and they have individuals come every 2 years and they undergo extensive testing. They rule out any evidence of asymptomatic disease. And when they looked at GFR, about 30% of the individuals actually had no decline in their GFR. We generally teach that creatinine clearance does decrease with aging, and that's true actually for majority of the patients that we see. But patients, they did see that 30% had no decline in GFR. So again, it raises the question that, what is related to aging and what is actually related to disease process, and we are still learning about that. There is progressive decline in ability to excrete a concentrated or dilute urine, a delayed or slowed response to sodium deprivation or sodium load, decreased level of renin and aldosterone, increased dependence on renal prostaglandins to maintain perfusion. That's why when you see you start patients on NSAIDs, they are prostaglandins inhibitors, and you can see that the renal function deteriorates because older kidney is more dependent on renal prostaglandins to maintain perfusion. There is decrease in vitamin D activation, and that you have a decreased production of 125 hydroxyvitamin D, so that may decrease to slightly increased level of parathyroid hormone in older patients. Clinical implications, I think the most important thing is that we should always look at creatinine clearance because it really affects the way we are prescribing medications. Serum creatinine values are not reliable estimates of renal function because there is less muscle as we get older. So serum creatinine, even though a patient may have renal dysfunction, serum creatinine may still remain the same. So that's not a good indicator for renal function. Use of drugs that inhibit renin, angiotensin, aldosterone systems such as ACE inhibitors and angiotensin and aldosterone receptor antagonists can contribute to hyperkalemia in older adults. And acute renal failure develops faster with relatively minor stressors and carries higher mortality. This is just the formula for calculating creatinine clearance. These days we actually don't use that because it's already calculated for you. This is the formula that modification of diet in renal disease or MDRD, where when you get your lab work, the creatinine clearance is already calculated. Again, the question which we asked before, and I know the answer was all over the place, but the ability to excrete acid load does decrease with aging. There is decrease in concentrating ability, there's decrease in diluting ability, and there is decreased metabolism of parathyroid hormone. So the answer was that there is the erythropoietin production is relatively unchanged as patients get older. Okay, so just a little bit, I just want to talk about the nervous system. This is a patient, 70-year-old. She's a retired school teacher who comes for a routine follow-up of her blood pressure. During her visit, she comments that she's concerned about her memory. She notes that she's having more difficulty remembering the names of individuals she knows. When she meets them, she also complains of misplacing her keys. Okay, so the question is, which of the following is least consistent with normal aging? Delayed retrieval, decreased speed of processing, forgetfulness that interferes with independent living, decreased multitasking performance. Okay, so majority of you, got it right, that forgetfulness which interferes with independent functioning. I just want to mention that, even people when they complain, they have memory complaints, we should actually take them seriously. In the past we used to say that if somebody says that, oh, I'm having problem with my memory, if they are able to express that, we don't think that they have actually dementia. They have underlying memory problems. I mean, that's not the case now. It's because we are learning that before patients have symptoms or clinical expression of Alzheimer's disease, the changes in the brain are there for maybe 10 to 15 years before you actually see the clinical expression. In fact, the Alzheimer's Association and National Institute of Aging just in April released new guidelines for the diagnosis of Alzheimer's disease, because the last time they released the guidelines was about 25 years. So now they actually have come up with 3 stages of Alzheimer's disease. One is preclinical, where you actually have no symptoms. So you are really looking at some biomarkers which are positive at that stage, but patients have no symptoms in terms of memory complaints or other problems with their function. And then what we call as mild cognitive impairment, where patients do have memory problems and they may complain that they are having problem with their memory, and the caregivers may say that, but there is no interference with their day-to-day living. So that's mild cognitive impairment. And then you actually have dementia, when we know the patients have not only problem with their memory, but one other area of intellectual function has to be affected, and it has to interfere with your day-to-day activities. So I think we are taking more seriously that patients who have memory complaints, we should actually do evaluation on them and follow them. Yes, you had a question? Yeah.
Are we using Dr. Nagel's new blood test as a clinical indicator of Alzheimer's at this point?
Yeah, I mean, I think, his test is sensitive to, detecting. I mean, I think we really need to actually study that more as to what clinical implication it has, because, for the same reason, we don't really recommend doing like a genetic testing on patients, because we do think that we could see some of the risk factors like apolipoprotein E4. I mean, I think this is a remarkable, the discovery that he has done, but it really need to be tested now in clinical application, because I think you want to take a look at it, what the specificity of the test is also. So if the test is negative, can you rule out that the patient doesn't have Alzheimer's disease? Yeah. So I think it's a remarkable work that he's doing, and but people actually from the National Institute of Aging are in touch with them, because they have what they call is like a neuroimaging initiative. So they are actually looking at patients who over the years would develop Alzheimer's disease. So it would be nice to get those blood samples and actually doing testing on that how early you can detect whether the patient has Alzheimer's disease or risk for Alzheimer's disease. Yes? Can you speak a little louder? I can't hear.
Sure. So having what you just said with the diagnostic tests, so then how are we diagnosing people or classifying them as preclinical or stage 1 if they're not having symptomology and we're not really running? I mean, are they just randomly doing blood work on people and seeing if
yeah, I think there are some biomarkers which are actually available, because you are actually maybe looking at the amyloid load that people have. So that's only for research purposes. So the preclinical stage is just for research purposes. But we know that there are some biomarkers in terms of amyloid. And now there are actually PET scans available where you can actually look at the amyloid load. There's also a nuclear scan which was going to be approved by FDA, which can actually look at the amyloid load. So I think the preclinical stage They wanted people to be aware of that, but that's really nothing clinically we are doing. In terms of mild cognitive impairment, because patients really don't have any functional problems, they require neuropsych evaluation. So if you have greater than 1 standard deviation from the normal, like age match controls, so there are criteria that when we can say that somebody has mild cognitive impairment. And then, of course, when patients have dementia, we can't say people are demented unless there is documentation that it's actually interfering with their day-to-day function. I think the reason I wanted to point that out is that, we used to just think that, oh, patients are having memory complaints, we don't need to take that seriously. But we do. Even though, right now we don't have really good medications which could slow down the mild cognitive impairment. But I think it's clear now, they say that, what is good for heart is also good for your brain. So the brain health is equally important as cardiovascular health. So whatever you are doing, making sure we are treating hypertension, diabetes, people exercise, so all those things which we do for our cardiovascular health really benefit our brain health also. Okay, so just briefly, I know we're running out of time. There's no change in memory in terms of sensory. The memory impressions are made whether you're seeing things or hearing things. A short-term memory, actually, there's no change. It is believed that one type of memory, which is called working memory, is most affected by age. And that's the type of memory, for example, somebody, you hear a phone number and then you retain that. You have to retain that for a while before actually you can store that in memory. And that's the problem that the older patients have. But there's no change in short-term memory or long-term memory. And long-term memory is procedural memory, which remains unaffected, and the semantic memory late in the stages of aging may get affected. And that's really referring to memory of facts and concepts. But procedural memory does not change with aging. Intellect, that actually there is crystallized intelligence, which is learning and experience, is stable or improves with age. Fluid intelligence, which is the problem solving with novel material requiring complex relations, declines rapidly after actually adolescence. So there is decline in fluid intelligence. It just takes also older people a lot longer to do things. They can learn the same things as younger individuals, but it takes them longer. So you have to really give them time to learn things. They can't learn it as fast as younger individuals do. And so processing speed and reaction time and mental processing time does become slower with age. So that means, we need to spend a little more time with our patients. You can't quickly tell them things and think that it registered with them. Language actually improves, vocabulary actually improves with age, in terms of syntactic skills, which is combining words in a meaningful sequence. There's no decline with age. Attention, there's no change. Executive function, ability to conceptualize or plan doesn't change with aging. So when you see deficits in these areas, then that should be a red flag that we really need to evaluate patients. So in terms of age-associated memory impairment, we do know that there is decrease in processing speed, decrease in multitasking performance, and impaired or delayed retrieval. I have this problem. The name is just at the tip of my tongue and I can't remember it, and then I will remember that later on. So it starts early. You don't have to be that old. So, they always say that, we all misplace keys, but I think the question is, if you don't know what the keys are for, then that's a problem. Vision and hearing, there is decreased in accommodation, presbyopia, which is the most common age-related change, which occurs in the elderly. Glare tolerance, adaptation, color discrimination does change. You're all aware of that as people get older, hearing problems are very common, presbycusis, which is high frequency hearing loss, is quite common in the elderly. That means that people don't understand when there's too much background noise going on. And that was one of the things I know in the ER that they are going to do, that having a place where there is not that much extraneous noise, because people do have trouble understanding when there's a lot of noise. So I think we just need to be aware that these are the changes which older patients have, making sure that we allow them sufficient time for older patients to process new information. And then you know that health literacy is another issue, that a lot of people who are even educated do not understand the medical information that we are giving them. We need to speak slowly facing the patient. Don't speak louder thinking that every old person is hard of hearing. Making sure that we are at their level. They could read our lips. I mean, talking with your back towards them, not a great way to communicate. And always use repetition to ensure that instructions were clear and your communication has been effective. The so-called teach back, that whatever you told them, make sure they understood what you told them. Laboratory, just word about that. Most of the laboratory results do not change with aging. I mean, a couple of things decrease. We already talked about creatinine clearance, PaO2, serum albumin. I mean, there's some question whether that decreases with aging. Now, few tests do increase. Sometimes you'll see elevation of alkaline phosphatase. SED rate is slightly increased in older patients. We do know the postprandial blood sugar increases, even though the criteria for diagnosing diabetes don't change with older patients. And there is some increase in total cholesterol and triglycerides. Having low hemoglobin is not a part of aging process. So if somebody is anemic, we need to investigate that why they are having anemia. Just a word about that. I mean, what happens to patients in the hospital? And I think this really, again, talks about the why we have actually developed this ACE unit. I mean, you have changes with usual aging, and on top of that, the things which we do to patients when they come to hospital in terms of immobilization, not having them being properly hydrated, putting them on bed rest. That even causes problem with their pulmonary function. No glasses, no hearing aids. Then we put them unnecessary on these tethers. Catheterizing people for not proper indications. So if people don't need IVs, fluids, I mean, should have HEPLOG. If they don't need catheters, we shouldn't be putting catheters in them. We shouldn't be restraining them. And again, all these things actually contribute more to problems that they can have in terms of their function. So I think that's really been the goal, that what we need to do in the ACE unit, and then really spread that type of care across the hospital. So just concluding that aging is associated with reduced functional reserve and a compromised ability to cope with stressors. That's why whether coming to the emergency room or hospitalization is an additional stressor to older patients, and elderly are very heterogeneous groups. So we really need to provide so-called patient-centered, individualized care, looking at the person as a whole, and always think of interventions which may be useful in helping patients cope with or overcome some of the changes brought by normal aging, because we don't need to add additional stressors to them unnecessarily. And again, as I said, that a lot of it is related to how our lifestyle and exercise, we all should think about building our reserves, because even if you have sickness, you are able to deal with it a lot better if you have better reserves. So when I talk to my patients, and I mean, always I'm trying to cut down on their medications, and I tell them that there's one thing I could recommend to them and that's exercise. And it's never too late to do exercise. They actually have shown, even in the nursing home patients, that they were doing lower extremity resistance exercises, and they were able to reduce the risk for falls. And even balance exercises like Tai Chi are also helpful in patients. So we just have to make sure that we work with more non-pharmacologic things rather than giving them medications for everything. Okay, thank you. And any questions? Okay, thanks.